Good evening, everyone, and a very warm welcome to the first live stream of 2025. Sorry. Okay. We are back on Oral Pathology 360, and we are excited to kick off this year with an insightful session on cytology and histology synergy in diagnosing salivary gland lesions. But before we begin, I'd like to extend a special welcome to our channel members. Um, we have some new members, that is Doctors Madhura Patil, Dr. Prasad Harikrishnan, Dr. Hind El Hag, Dr. Shrikant Kutina, Dr. Lloyd Jo, Dr. Abdul Rahman Muhammad, Dr. Vandana Shah, Dr. Saiti P, and Dr. Amina Sultana. And I have to thank them all for joining our community. Also, if you are interested to be a community member, remember one of the perks is getting a certificate for participation and attending the live streams. So, how does this work? You basically become a member by, if you're not already a member, you become a member by clicking on the join button, which is below the channel right now. You see it below saying join. And after that, you attend our live streams naturally. You interact with us in the chat, in the live chat. And after the live stream, you will find a link that we will share um, on the community tab. So when you open the channel right at the end, after the list of videos and live streams and um, playlists, at the end is community. If you go there, you will see all the posts from the channel, and if you click on there, you will be able to see the post that is sharing the link for the feedback form that you have to fill up to be able to get your certificate. Once you fill that up, you will get your certificate within 24 hours. We also have another very exciting update. We are coming to you with another online masterclass. Everybody enjoyed the last one, so we are bringing you another one. This one is on oral potentially malignant disorders. It is happening on Saturday, 8th of February 2025 from 4:30 to 8 p.m. Indian Standard Time. And if you want to see the time in your zone, you can see that on our website. It will be conducted by Dr. Omar Khujan, who, as you know, is a globally recognized expert on the topic. He is on the top 2% of scientists globally, and he has done a lot of work on this topic. So definitely don't miss this chance. You can join either by scanning the QR code and going to the link. There's also the registration link in the description below this. And then otherwise, you can just go straight away to our website, oralpathology360.com, and you will be able to actually see the details there. Now, let's move on to tonight's session. We are honored to have with us Dr. R.G. Weisman Pinto, a globally renowned pathologist and a trailblazer in cytology and histology with over 300 publications and decades of expertise. Dr. Pinto will guide us through the fascinating synergy of cytology and histology in diagnosing salivary gland lesions. Now, without any further ado, let me bring in Dr. Pinto, and let's get on. So let me. Oh, we are missing Sir right now. I'm hoping that everything is working on YouTube. I did not check the sound. So let me do that while Sir joins back in. Is everything okay? Yes. Okay. He should be here with us any second. He's been having a little difficulty joining in. So let me see who's with us already. And yes, we have Dr. Bhuvan. Hi. Dr. Yolandi. Hi. Dr. Alexander Nirenberg. If you all remember, he just was the last speaker of last year. Dr. Sweta Acharya. Dr. Abdul Rahman. And I think that must be Sir calling me. One. Sorry, I will just take this.
Yeah. Yes, sir. Can you hear me now? Sir, I can hear you, but the thing is, yeah, you cannot hear me. No, it's fine. I see if you can hear me, I'll keep on talking. You tell me when to start. Okay, tell me on that line when to start. Okay, just hold on, sir. Yeah, sure, just sure, sure. Okay. Huh?
Okay, everyone. So,
Okay.
Sir is having a little problem. I'm going to just share his slides and he's going to present. So, we'll just go to the slides.
Sir, yeah, can you see the slide? Yeah, I can see the slide. I can see. You can start speaking. You can start. Good evening, my dear friends. I'm going to talk on cytology and histology synergy in diagnosing salivary gland lesions. This is part one of my talk. This is to elevate the diagnostic excellence. I would like to thank Dr. Mandana for the invitation. Now, in this talk, it's basically the talk is on salivary glands, and today I'm going to talk about the name salivary, how it is derived, a brief introduction. Let's see this come. Put it on. A brief introduction, the anatomy of the salivary glands, the different classifications, and then some tumors of the salivary glands, the benign tumors, the malignant tumors, the malignant tumor. Yeah, you can hear me. You can hear me. Yes, I can hear you, sir. The malignant tumors and the tumor-like lesions. Now, also in my next class, I will be talking to you about the new entities, the genomic analysis, as well as the classifications, the grossing of salivary glands. Today, I'm going to concentrate on more basic things like the normal anatomy and the histology. Now, the word salivary comes from the Latin word which means salivos, which means spittle. It also comes from the Greek word xylon, which means spittle. So basically, the old system of medicine, modern medicine, we are following the European, Greek, Latin. So these are the words which the word salivary is derived. So spittle. Parotid means para-otic, means the beside the ear. Lingual means the tongue. Lingua is tongue in Latin. So basically, these words are derived from the Latin and Greek. Now you know cytology and FNAC and histopathology. They have been to be used together. But before cytology and histopathology, you should take a detailed history of the patient, how long the swelling is there, and if there are any other symptoms, if there's any history of surgery, and a total history of not only the patient but the family history. And also, we should take into account the imaging, the ultrasound, the scan, CT scan, MRI, and then do the FNAC, the fine needle aspiration cytology, and the histopathology. Now, when we reach the fine needle aspiration cytology, we should realize that there is a sensitivity and specificity. The sensitivity is 60 to 100%, and the specificity is 90 to 100%. So, besides this, we should know that now, when you do an FNAC, what are the cells that you get? The cells that we get are the cell. When you do the FNAC of the salivary gland, you get acinar cells, the mucus cells, the ductal cells, the myoepithelial cells, oncocytes, fat, sometimes lymphoid cells, and others. Can we have the next slide on the screen? Can we have the next slide? So this is the salivary tissue. You can see the acini, you can see the ducts. This is the histopathology, and there is a little fat in between. The fat is there because as the person grows older, there is the more amount of fat. So it has got salivary acini. The acini have got there are epithelial cells, myoepithelial cells, and there are the intercalated ducts which are seen on histology. Can we have the next slide, please? Can we have the next slide on the screen? Yeah. So this is the FNSA. Yeah, this is the FNSA, and you can see that there are the salivary acini. You know, when the tissue is removed on and made on a slide, you can see that there are grape-like clusters of these acinar cells which are seen stained bluish, and you can see also the duct which is stained reddish. So on cytology, we will see the acini, the ducts, the myoepithelial cells, and sometimes fat, sometimes lymphocytes, RBCs, and others. Can we have the next slide on the screen? Can we have the next slide on the screen, please? This is again the salivary acina. You can see a duct and you can see the grape-like clusters on FNAC of the salivary acini. Can we have the next slide, please, on the screen? Yeah. So now once we have seen the normal, we are going to see some conditions. Now, the most common condition is a tumor called as pleomorphic adenoma. So this is the picture of an FNAC of a pleomorphic adenoma. Now, you know, pleomorphic adenoma is also called a mixed tumor of the salivary gland, and it is a benign tumor, and it is common in women between 40 and 60 years, but it can be seen at all ages. It can be seen also in men. It is one of the most common tumors of the salivary gland. It's common in the parotid, and in the parotid, it occurs in the superficial lobe as well as the tail and the anterior and posterior. It can also present as a parapharyngeal mass. The pleomorphic adenoma can also be seen in minor salivary glands, especially in the palate. Now, on gross, this has a rubbery tumor like firm white in color. It is bossylated and about 2 to 5 centimeters. It is well circumscribed, but there may be pseudopodia. So, that is the reason that this tumor can recur. So microscopically, you can see that there is a epithelial cells, myoepithelial cells, and there is a myxoid material, myxoid stroma. So there's an intimate admixture of the epithelial and the myoepithelial cells and the stroma. The stroma is myxoid, fibromyxoid, and it is actually produced by the epithelium and the myoepithelium. Can we have the next slide? So this is the pleomorphic adenoma. Again, this is also a FNAC of the pleomorphic adenoma. It is showing you a lot of myxoid material and the epithelial and myoepithelial cells. Sometimes, can I have the next slide, please? Sometimes the pleomorphic adenoma on FNAC is very cellular, and sometimes the myxoid material is abundant. So the myxoid material helps us to differentiate that this is the pleomorphic adenoma. And if it is only cells, lot of cells, then the differential diagnosis is sometimes a monomorphic adenoma or a myoepithelial rich pleomorphic adenoma. Now, some pleomorphic adenomas, as I told you, are very cellular. They are round. Sometimes they may have a lot of spindle cells, but they are usually benign. Even if they have mild atypia, they are benign. Now, some of the pleomorphic adenomas, they can recur because there are pseudopod-like extensions and it is not totally excised. Can we have the next slide, please? Can we have the next slide? So, this is the pleomorphic adenoma. So with a lot of the epithelial and myepithelial cells. Can I have the next slide, please? So these are all pictures of pleomorphic adenoma with myxoid and epithelial and myoepithelial cells. Can we have the next slide, please? Yeah. So now you see that sometimes the epithelial cells are more abundant. The previous slides you saw a lot of myxoid material, but sometimes the cellularity is more of the epithelial cells and myoepithelial cells, and you can see they have the plasmacytoid appearance. They have a lot of eccentric nuclei and cytoplasm, and the nuclei are by and large regular. But in some areas, you can see there is a variation in the size of the nuclei. So there's an atypia. There is a mild degree of pleomorphism. This is not to be considered as malignant. Only if it is diffusely there throughout, then you have to see many more sections, many more slides, and many more smears, and also go into the clinical aspect of the case. So this mild degree of atypia, mild degree of enlarged nuclei is not to be considered malignant in a pleomorphic adenoma. Next slide, please. So again, the pleomorphic adenoma with a chondromyxoid background and the epithelial and now, myoepithelial cells can be spindle shaped, can be plasmacytoid, can be clear cells, can have different types of formative patterns. Can we have the next slide, please? Can I have the next slide? So, at other times, there may be just not no myxoid material, but basiloid cells like this, which are seen here. So when you have a lot of basiloid cells, we should consider that this is the monomorphic adenoma or a basal cell adenoma of the salivary gland. Can I have the next slide, please? Can I have the next slide? So these are all lot of RBCs in the background and cells which are basiloid. So this is a basal cell adenoma. Sometimes you have to differentiate basal cell adenoma from a basal cell carcinoma or a basal cell adenocarcinoma. Now this is an example of a basal cell adenocarcinoma. So you have a lot of cellularity, it invades into the surrounding, pleomorphism, necrosis, and the important thing about a basal cell tumor is that there is nuclear palisading. The nuclei are palisaded at the periphery of this island. Next slide, please. Next slide, please. So this was a basiloid tumor. Now coming to the next tumor, benign tumor, this is the Warthin's tumor. Now, Warthin's tumor is a tumor that occurs exclusively in the parotid. It is seen in males and those who are smokers. Out of 10 patients, 9 will tell you that they give a history of smoking, and it is seen in males. Now, in Warthin's tumor, what do we see on FNAC? We see a lot of lymphocytes, inflammatory cells, and the oncocytic cells. The large pink orangophilic cells are the oncocytic cells, and in the background you can see the lymphoid cells. Can I have the next slide, please? Can I have the next slide, please? So the oncocytes are cells which have got a pink cytoplasm, and the oncocytes are pink because they have a lot of mitochondria in their cytoplasm. Can we have the next slide, please? So now Warthin's tumor is a tumor which has got different patterns. So it has got a lot of lymphoid cells, and there are the papillae which are lined by the oncocytic cells, and also there are the pyramidal cells. And they form clefts, and sometimes you may get just cystic spaces, and you may get on FNAC clear fluid, or a fluid which is having a lot of necrotic material and oily material. Like, can we have the next slide, please? So after oncocytoma, we will now, can I have the next slide, please? After the Warthin's tumor, the differential diagnosis is oncocytic lesion. So these are the oncocytic cells on FNAC. Now, when you see oncocytic cells on FNAC from a salivary gland, the possibilities are, number one, that it could be an Warthin's tumor. So in Warthin's tumor, you will see that there are a lot of lymphoid cells and in the background, and the oncocytic cells. The second differential diagnosis is on oncocytoma. An oncocytoma or oncocytic tumor. Here there will be only oncocytic, very cellular, only oncocytic cells, or these are the Huttle cells, or these are the Eskenazi cells, and they have got, they are arranged in three-dimensional clusters, and there are very few lymphocytes. So this is the oncocytic cell. Third differential diagnosis is oncocytic metaplasia, which sometimes you may see in salivary gland tumors. Can we see the next slide, please? So these were the oncocytic cells. Can we have the next slide, please? Now, besides oncocytic cells, and that will be Warthin's and oncocytoma, the next you can have mucoepidermoid carcinoma of the salivary gland. Now, mucoepidermoid carcinoma will have three types of cells. Can we have the next slide, please? Can we have the next slide, please? The mucoepidermoid carcinoma will have three types of cells. There will be mucus-containing cells, which clear cytoplasm. There will be squamoid cells, and there will be the hybrid cells or intermediate cells. So there are three types of cells. There will be clear cells, there will be squamous cells or squamoid cells, and hybrid cells, pyramidal cells, and small basaloid like cell. Now, the quantity or the proportion of these three cells is variable. Sometimes mucus cells are abundant, then it becomes a low-grade mucoepidermoid tumor, and it is cystic. It could look like a mucocele. Second, many of the mucoceles you have to take many sections because they may be mucoepidermoid, low-grade mucoepidermoid carcinoma. Second, lot of hybrid cells and squamoid cells and solid. Then you will again mucoepidermoid carcinoma of intermediate grade and higher grade. So depending on the amount of mucus cells, the intermediate cells, and the squamous and the hybrid cells, your diagnosis is mucoepidermoid tumor, mucoepidermoid carcinoma. When it is low grade with a lot of mucin, then the prognosis is very good. The 5-year survival rate is very high. And if it is very solid, then the 5-year survival rate is poor. Now, another important thing is mucoepidermoid carcinoma is the most common cancer of the salivary gland, which you see in children. So you can see, so it's the most common salivary gland tumor in the children. It can be even be bilateral. The tumor can be bilateral. So that is mucoepidermoid carcinoma of the salivary gland. Now, one should always remember that you have mucus cells, you have epidermoid squamous cells, and the intermediate cells. Now, if the mucoepidermoid tumor, it is the pleomorphism is minimal. So if there is a lot of hyperchromasia, there is a lot of pleomorphism, lot of keratinization, then your diagnosis may not be mucoepidermoid. It may be a squamous cell carcinoma or a adenosquamous carcinoma. So here you don't get much of keratin or cyst formation or marked hyperchromasia and pleomorphism. So that is the feature of mucoepidermoid. The important feature is that it can be seen in children. The youngest patients I have seen is around 9 years old with mucoepidermoid carcinoma. And so it can occur in different age groups, and it has got in different connotations. Next slide, please. Next slide, please. So these are all the FNAC of mucoepidermoid carcinoma, mucous cells and intermediate cells and squamous cells. Next slide, please. Next slide, please. So these are examples of all mucoepidermoid carcinoma, where there are mucous cells, the epidermoid cells, and intermediate cells. Next slide, please. Next slide, please. So these are examples of mucoepidermoid carcinoma. Can I have the next slide? So these are the all slides of mucoepidermoid carcinoma. Now, can I have the next slide, please? Next slide, please. So this is also FNAC showing the different types of cells. Can I have the next slide, please? Can I have the next slide, please? Can I have the next slide, please? Now, after mucoepidermoid carcinoma, we will go to adenoid cystic carcinoma. Can I have the next slide, please? Adenoid cystic carcinoma is has a cribriform pattern. Can I have the next slide, please? Now, adenoid cystic carcinoma has got a cribriform pattern, and on FNAC, it has got cribriform pattern is on histopathology, but on FNAC, you will see that it is very cellular. There are small round cells with round nuclei and lot of material, extracellular hyaline material, which forms the cell balls, round hyaline like chondromyxoid, round material which form round balls, spherical balls, and they have got these cells which are small and hyperchromatic, which sometimes in in FNAC also you can see fragments which are having the a cribriform pattern. Can we see the next slide, please? So this is the FNAC of a uh, of an adenoid cystic carcinoma. Now, adenoid cystic carcinoma has got a cribriform appearance on FNAC, on histopathology. Can I have the next slide, please? Can I have the next slide, please? So now the adenoid cystic carcinoma has got certain very characteristic features. It causes sometimes pain because it invades the nerves. It has got adenoid cystic carcinoma has got a propensity to invade the perineural invasion, has got a capacity for perineural invasion. And adenoid cystic carcinoma can have a tubular pattern, can have a solid pattern and cribriform. The solid pattern has got the worst prognosis and the 5-year survival rate is very poor, whereas the tubular pattern has got a better prognosis. Can I have the next slide, please? This is squamous cell carcinoma of the parotid. So when you have squamous cells of the parotid, now you should be very careful that we are dealing with whether it's a mucoepidermoid, but when they are more hyperchromatic and squamous, then you should think that the first possibility is that this is a metastasis. Now this is a very important feature. When you have a metastasis, when you have squamous cells in the parotid or in the neck, the first diagnosis will be metastasis from a squamous cell carcinoma of the head and the neck, because pure squamous cell carcinoma of the parotid is very, very rare. So you have to rule out a primary. The reason is that if you write squamous cell carcinoma and a surgery is done, then there may be a primary in the upper aerodigestive tract in the head and neck. So the treatment would be not complete and not accurate. So that is why squamous cell carcinoma or a very high grade tumor of the parotid always rule out that there is a metastasis, is that this could be a metastasis from a primary elsewhere. This should be kept very much in mind. Otherwise, the surgeon will go ahead and do a radical surgery, and there may be still a tumor in the aerodigestive tract or in the head and neck region. So this is the squamous cell carcinoma, usually to be considered as metastasis, and the primary should be searched. Next slide, please. So besides squamous cell carcinoma, sometimes you may get neuroendocrine carcinoma or a small cell carcinoma. You may get a small cell carcinoma. Can I have the next slide, please? So small cell carcinoma or neuroendocrine carcinoma are, the cells are very small, they're hyperchromatic, the chromatin is powdery chromatin, finely stippled chromatin. And then what happens is that sometimes there is nuclear molding, the cells are very fragile and they get broken down. Now, after these tumors, we have here on the screen a case of a chronic sialadenitis. Sialadenitis is a very common condition in the salivary gland. So there are the ducts, the acini, and lot of inflammatory infiltrate fibrosis. Sometimes it is so hard that it looks like a tumor. So it's called sometimes in the submandibular as a Kuttner's tumor, but it is a chronic non-specific sialadenitis. Also, we have to keep in mind for this chronic non-specific sialadenitis that these lymphocytes are not a part of a lymphoma process. Secondly, these lymphocytes should also be not a part of the IgG4 related disease, which I will cover next lecture. Can we have the next slide, please? Next slide, please. Can I have the next slide, please? So after the small cell carcinoma, we can have the other high-grade tumors of the parotid and the salivary gland. Next slide, please. So these are all very high-grade. Now, sometimes you can get what is known as the salivary duct carcinoma. Can I have the next slide? You see how hyperchromatic, pleomorphic these cells are on FNAC. So this is a salivary duct carcinoma. Next slide, please. Now, salivary duct carcinoma is a carcinoma just like a breast, ductal carcinoma of the breast of the female. But here, the salivary duct carcinoma is common in the males, elderly males, and it has the markers just like a breast, GCDFP. It has got androgen receptor, it has got Herceptin positive, and it has got a very high grade and very poor prognosis. Lot of just like a breast carcinoma, lot of comedonecrosis, hyperchromasia, and necrosis. And so this is the salivary duct carcinoma. Now coming to primary carcinomas of the salivary gland, they account for 0.3. Important, the salivary duct carcinoma, these they could be, the highest are in the oral cavity, retromolar, floor of the mouth, tongue, rather than the parotid. But they can also occur in the major salivary gland and the minor. Can I have the next slide, please? Next slide, please. Now, important things clinically: rapid increase in the size, pain, rapid increase in the size of the mass. It is there for a long time. Suddenly increases, pain. It is fixed to the structures, ulceration, cervical lymph nodes, and facial nerve paralysis. These are all points which point clinical features which point to a malignant process. And of course, the imaging will also collaborate with your findings. So now the mucoepidermoid carcinoma is the most common salivary gland malignant tumor. Then is the adenocarcinoma, not otherwise specified. Acinic cell carcinoma. Then there is the adenoid cystic carcinoma. Then there is a polymorphous adenocarcinoma, which was in the old days called as low grade. Malignant mixed tumor, which we'll discuss next time. Basal cell adenocarcinoma and epithelial myoepithelial carcinoma. Also, we will be discussing next time. Next slide, please. So besides, you have oncocytic carcinoma. Now, oncocytoma and oncocytic carcinoma. How to differentiate? You have to see the invasion of the capsule, vascular invasion, and necrosis. Then squamous cell carcinoma and undifferentiated. Undifferentiated can be lymphoepithelial, small cell carcinoma, large cell carcinoma. They have what is the stippled chromatin. Then malignant myoepithelioma and salivary duct carcinoma. Salivary duct is very rare, 0.2%. Next slide, please. Next slide, please. Then you have the others like intraductal carcinoma, mucin secreting carcinoma, combinations, intraductal carcinoma, sebaceous adenocarcinoma, cyst adenocarcinoma, clear cell. These are all rarities. Xyloblastoma. Very rarely you will find these. Next slide, please. Mucus secreting carcinoma, you may see many times. This mucoepiderm, mucus secreting, in combination, cysts, solid islands. Next slide, please. I've already told you that you get it in children. Next slide. So mucoepidermoid can be low grade, high grade, intermediate grade. Next slide, please. There are variants of mucoepidermoid showing focal spindle cell, oncocytic metaplasia, and sclerosing variant. Next slide, please. So these are examples of mucoepidermoid carcinoma on FNAC. Mucous cells and the intermediate cells and squamoid cells. This is a high grade like oncocytes. Next slide, please. Next slide, please. So this is again mucoepidermoid carcinoma. You are having the epidermoid cells, which are and as well as the mucous cells and the hybrid cells or the intermediate cells. Next slide, please. So I've shown you the different examples of this. Also mucoepidermoid on FNAC. These are all mucoepidermoid. Next slide, please. This is the histopathology of mucoepidermoid. Lot of mucin and the epidermoid cells and the intermediate cells. Next slide, please. So this is mucoepidermoid carcinoma. Next slide. All examples. This is the high-power view showing the clear cells, mucinous cells, and now mucoepidermoid carcinoma also has a lot of lymphoid material or lymphoid cells in the periphery. Next slide, please, which you can see on the left. So it can be low grade, it can be intermediate grade, and it can be high grade. Next slide, please. It can show perineural invasion. So this is a basal cell adenocarcinoma. You can see there's palisading and the cells are basiloid. Next slide, please. Next slide. Next slide, please. So these are all examples of basal cell adenocarcinoma. Next slide, please. So these are examples of oncocytoma. I think I will now end my talk here with a summary that I've covered the normal salivary gland, the cytology, the cells, and the histopathology. And also I've covered some salivary gland tumors which are common. And in my next class, I will be discussing more salivary gland tumors recently described and those which I have not covered, the metastatic, the tumor-like lesions, and also the genetic analysis and the staging, etc., and grossing of the salivary gland. So once again, salivary gland is a very vast topic, but we'll have in part two. And once again, I thank Dr. Mandana for the invitation. Thank you. Now I'm ready for any questions. Thank you. Hmm?
Sorry.
Yeah,
Sir,
yes.
sir, the
They could
questions
hear
are
me.
here on the screen. Can you see the screen?
Yeah. Just put it online. Yeah. If there are questions, you can just I can hear. Please tell me. Yeah. Brought the question on the screen. Can you read the screen? Not very clearly. Can you read it to me? I will answer. Okay. It says very informative session. In your experience, how often do we encounter cervical pleomorphic adenoma? Your experience regarding recurrence rate and pleomorphic adenoma. Yes. Now, pleomorphic adenoma, you will see thousands of cases, at least in your career, long career, you will see thousands of cases. Now, the recurrence rate depends on the surgeon. If the surgeon has done a very good surgery and the margins are free, then it does not recur. But, and if the lesion is smaller, picked up early, but the lesion can recur if it is bigger and larger, and there are like extensions, because pleomorphic adenoma shows what is known as pseudopod like extensions, or there are islands outside the main tumor, outside the capsule. So that is why it can recur in those situations. So the recurrence is not very common, but it does occur. It could be about, in my estimate, about depending on all the factors. What is also important in a pleomorphic adenoma is that one should always remember that pleomorphic adenoma can show a benign metastasis. A benign metastasis. A benign metastasis means that you can get small nodules of salivary of the pleomorphic adenoma in the scalp and other organs. It is to be considered as benign. There are some benign tumors which metastatize. So this is one of them. There are many others which I'm not going to say today because it may not be of interest to the dental. But so it can show benign metastasis. And I have seen out of the thousands, maybe a very few, less than 5, which can show benign metastasis. And benign metastasis, the thing is that they are very low grade, but they need radiotherapy to eradicate them. So that is the problem. And usually they will be seen in patients. These recurrences and benign metastasis will be seen depending on the patient's immune response. Sometimes the patient is operated, they're okay. After 10 years, they get a recurrence. And then they may be having an immunosuppression. A patient I've seen may be having tuberculosis. And then this metastatizes. You followed benign mets. So, today, that an immunosuppression or immunological status of the patient is very important in tumors as well. Okay, I hope I've answered the question. Yes, sir. Next question is from Professor Hiller, and he's asking. It seems that the diagnosis of high-grade MEC is becoming a difficult one to make, and it doesn't have the MAML2 gene. So, yes, not only all high-grade tumors of the parotid are a problem. because of they lose their genetic configuration, they lose their morphological status, so it becomes a problem. The high grade tumors of the salivary gland, and a very important thing is that metastasis should be ruled out. Many of them, because uh, metastasis is uh, these high grade tumors could be metastatic from somewhere else. And if they are localized or restricted or situated, then they have to be operated. Even on surgery, sometimes the high grade tumors of the parotid and all salivary glands are a problem. Now, there is another thing which I will be discussing in my next class. There are the new genetic markers and the new markers which are coming, which are the chromatin regulators, like INI1 deficient, SMARC A4, SMARC B1, which are also affecting the salivary gland. So, and these are also, which I'll discuss in my next class. So yes, I agree. It is a very big problem. All high-grade tumors of the not only salivary gland but in other organs as well. Next, I hope I.
Yes, yes, sir. Thank you. So the next question is a follow-up on that. Is how do you distinguish a high-grade MEC from a metastatic SCC on cytology only because of presence
Yes.
or lack of vaginitis?
Yes. The question is, how do you differentiate a squamous cell carcinoma and a high-grade mucoepidermoid carcinoma? Now, squamous cell carcinoma will have high grade, it will have keratinization, hyperchromasia of the nuclei, on the FNAC, keratinization, cystic change, and of the keratin type. And it will not have mucus cells and the smaller cells, whereas mucoepidermoid carcinoma by and large has got mucus, some cells, mucus cells, some epidermoid cells, and some the intermediate cell. So it is a lesser, it is a more bland type of cytology compared to the squamous cell carcinoma. So this, and so one should be quite aware that most of the mucoepidermoid carcinomas are the low grade and intermediate grade. Those which are very high grade are not common. And remember that when you have squamous cells which show abundant keratinization, abundant hyperchromasia, abundant pleomorphism, and cystic change with keratin, not mucin, then it is not a mucoepidermoid carcinoma, because mucoepidermoid doesn't have this, by and large has got a more blander look. Okay, I hope I. So the secret in cytology are two. Take as much as you have to do the FNAC maybe a few times, much more than 2 times in such cases, from different areas depending on the size. You can make 3 passes, 4 passes, and make a lot of slides, see many slides. So that is the secret of coming to a more specific diagnosis. But let me also tell you that sometimes very high grade salivary gland tumors, you can only grade them. You may not be able to come to a right histological diagnosis, especially with the new tumors setting in, being described, chromatin regulators, etc., which I will do next time. Okay? Yes. Thank you, sir. So there is one more question. Yeah. How do we differentiate cytologically between adenoid cystic carcinoma and polymorphous adenocarcinoma? Right. Now, adenoid cystic carcinoma usually occurs in the submandibular, sublingual parotid. It can also occur in the minor salivary glands, oral cavity, etc. Now, polymorphous low-grade adenocarcinoma is more common, much more common in the minor salivary glands, but it is very rare in the major salivary gland. Now, how to differentiate these two? Again, the things are lot of slides, make lot of material on FNAC, and adenoid cystic carcinoma is you have those round cell balls, which I showed you, hyaline balls of hyaline material, and cells forming a cribriform pattern. Uh, Now, so having a cribriform pattern. Now, the thing, so you have seen lot of material, lot of cells, and the cells are reasonably hyperchromatic. Now you should be very careful about this, because adenoid cystic has got a very bad prognosis. It invades the nerves, so they are quite hyperchromatic. Sometimes same picture you may see lower grade, and it may not be polymorphous low grade, it may be some another uh, low grade tumor, like monomorphic adenoma, etc., can also mistake for this. But adenoid cystic has got very round cells, have got these round balls of hyaline material cells, cribriform, tubular, and whereas polymorphous low grade will have a mixed picture. Mixed picture. They will have this adenoid cystic in a very small component, very rare component, but mostly it will be in ducts. It will be like a sclerosing adenosis. On histology, so on FNAC, it will have different patterns, tubules, sheets of cells, etc., with a blander look, of the cells, and less of this round balls. So this is now my advice is, all the people, the pathologists should have a very good idea of histopathology, and then they can put this, when you see the cells, compute it like a, try to map it, that this fits into. Sometimes you even get fragments on FNAC, which, so you have to be a very good histopathologist, experienced histopathologist, to pick up these areas and to come to them. And other thing is that adenoid cystic carcinoma causes a lot of pain, the nerves, and grows fast, is hard, whereas the polymorphous low grade, keeps on recurring. It is more softer, and it is the minor salivary glands. Okay, I hope I. Now there are many others which I have not covered, which I'll cover next time, like epithelial, myoepithelial carcinoma, and which I'll show you the pictures also, histopathology and epithelial, myoepithelial carcinoma, and the others as well, carcinoma X pleomorphic adenoma. Okay, yeah. Anything else? Yeah.
Yes, sir. There is a question which is how do you differentiate clear cells, often any-like cells, and cells with vesicular nuclei on histology?
Clear cells have got a clear cytoplasm. Now, this clearing can be due to mucin, can be due to glycogen, can be due to mitochondria. Now, orphan, he said orphan N, orphan Annie?
Orphan any cells.
Orphan Annie is the feature like cells. Orphan Annie is the cells you get in Hodgkin's. Orphan Annie eye appearance you get in Hodgkin's. They have got nucleoli. They are clear. They are, the nucleus is cleared. So that's often any appearance. And the what was the third one? What was the third?
So it is vesicular nuclei.
Vesicular nuclei. Now vesicular nuclei mean that the nuclei have a chromatin which is open. It is not hyperchromatic. It is not stippled. It is not clumped. It's a vesicular. And usually benign cells or low grade cells have a vesicular nuclei. So coming back, the clear cells have got clear cytoplasm. Orphan Annii, you will, and the company that it keeps, the Reed-Sternberg cells, Hodgkin cells, orphan Annii, of course, you can also get in the papillary carcinoma of the thyroid, which is metastatic. So orphan Annii, sometimes you can get in the salivary gland as well. But these are cells which have got clear clearing of the, they have got a clearing of the nuclei. So there is an orphan Annie, that is which you see in papillary carcinoma of the thyroid. They have got a ground glass like appearance, clearing. And the third one that he asked was, what was the third question? Vesicular nucleus. So vesicular nucleus have got and the company that the cells keep, papillary carcinoma, orphan Annii will have papillae, and then vesicular will be vesicular, and clear cells will be as I've described you. Yeah. Next one. And I've also told you, like Hodgkin cells, they can also have clearing, and the company that they keep lymphocytes, histiocytes. So there's a follow-up question to that. Yeah. What will you think if you have a predominance of orphan Annie-like cells in a salivary gland tumor? You know, often Annie cells is not common in the salivary gland. There are some tumors of the salivary gland which look like the thyroid, but it is very rare. It is extremely rare. Vesicular nuclei are common. So we have one last question. Yeah. This is how do you diagnose Kuttner's tumor on FNSC? Now, Kuttner's tumor is a submandibular salivary gland lesion. So it will be firm, it will be hard to feel. And you do an FNSC, and on FNSC, you will get salivary acini, you will get lymphocytes. And as it is fibrous, some fibrous tissue, spindle cells can come if you do. So basically, it is by doing many passes, many FNACs, you will be able to diagnose that this is a chronic non-specific sialadenitis or inflammation, which is called a Kuttner's tumor. So that is, it's basically now. And if you are working in a very high output center in say a Western country, these lymphocytes, you'll do flow cytometry to rule out a lymphoma. Flow cytometry to rule out lymphoma. Otherwise, you will see that these lymphocytes are different types of, not only small lymphocytes, plasma cells, medium-sized lymphocytes. You know, they are like a varied population of lymphocytes. They're benign, they're bland, they have got a bit of fibrous tissue and salivary acid. So it is the clinical experience as well as the doing large number of passes to diagnose this. It's not difficult to diagnose Kuttner's tumor and okay, on FNAC. Anything else? Any other question? Thank you, sir. That was, I think, all the questions. Yeah. So just to summarize, next time I will cover some of the tumors which I didn't cover. There'll be a lot of histopathology and newly described entities. There are plenty of newly described entities of these salivary gland tumors. So once again, I thank Dr. Mandana for all your invitation and all your yeah. You're most welcome, sir. It was our pleasure to have you here with us. May I also say that Dr. Mandana met her in 2012 for a conference in Goa, and she has been doing a lot of academic work, and she was also got a lot of awards. I saw Inspire Award, etc., etc. So keep up your good work, Dr. Mandana. Thank you. Thank you so much, sir. Thank you. And sir, we have a little certificate for you here. I know you cannot see it probably, but thank you so much. Thank you. It's thank just you. A token of our the certificate can be in my heart and in my mind. I know. Thank you. I know. It is just. Thank you. I know it's just a token. Really. Thank you. Thank you. Thank you so much, sir. Thank you. We look forward to seeing you for the next lecture. Sure. Thank you, sir. Thank you so much.
Right. Okay. So, yes, we are back on our regular system, and I have to just do two things, that is, share the next programs with you. And I'm wondering if you can hear me there. Yeah, okay. Right. So, upcoming is one journal club with authors, that is on the 25th of January. Please note the time, it is 1400 IST. Okay, it's not a normal time. And another one is going to be the next Tuesday program after 2 weeks on salivomics by Dr. Samapika Rotary. So I do hope you will join us for all of this. And any of you who are waiting to get your certificate, please look in the community tab, and you will find the link. If you do not find the link, you know where to find me. Just send me a message. Okay, and with that, let's say bye. Yes, everything seems fine. And yeah, okay, let's just call it a day. Thank you, everybody, for joining and for staying. Although we had some issues, thank you, anyways. Thank you for being here. Bye. And have a wonderful evening. See you all next time.